So we're going to talk about nystagmus in children with Down syndrome. But the first thing I want to do, if I can get this thing to work, right? Whoops, sorry, I need to go back. And now I don't know how to go back because that was the problem I've got here is that I'm on my son's computer and I can't go back. Um, his mouse is very different to mine, and it's the weirdest mouse I've ever used. So that previous slide simply said, don't confuse nystagmus with astigmatism, because the two words do sound rather familiar, and some people do mix them up and think their child has got nystagmus when they've actually got astigmatism. Astigmatism is like long sight and short sight, something that is correctable with specs. And we've almost all got astigmatism, probably quite a small amount. Some of us have got more, but it is not the same thing. So nystagmus, let me see if I can get this video to work, is this, which is constant, uncontrollable wobbling of the eyes. In most cases, it's a horizontal shake of the eyes, and both eyes move together. That's what we mean by nystagmus. And it can be a large movement, a small movement, and it can vary. Oh, and there he is picking his nose. That's what we didn't want to see. I meant to stop it before we got to that. So it's an involuntary rhythmic movement of the eyes that starts in the first few weeks of life. It's very rarely there at birth, and it appears when the child is just a few weeks old. What causes it, we don't know. It's still a bit of a mystery why it appears. But what we do know is that there are different types of nystagmus. So I'll just take you through these. So the first one is pendular, in which the eye movement is equal in both directions. So the eye just swings backwards and forwards. Now, apparently, when babies are very little, pendular nystagmus is the first type they have. And after a few weeks or months, it turns into jerk nystagmus, in which the eye moves quite slowly in one direction and jerks back. So most children and adults who have nystagmus have that type of nystagmus. And again, we don't know why it changes and what the implications are, but that's the sort of movement that we think of as usual nystagmus. And then there's latent nystagmus. I haven't got an illustration of this because it appears only when one eye is covered. And sometimes children start off with pendular, then it moves to jerk, and then it goes latent. So it looks as if they've grown out of their nystagmus, but if you cover one eye, it's still there. And if a child has latent nystagmus, it doesn't affect them when they've got both eyes open, but sometimes it can sort of manifest, bleed through, if you like, when the child is very tired, stressed, or ill. So most of the time it won't be visible, but it always carries the risk of appearing when a child is under stress. And then there's endpoint nystagmus, which only appears when a person looks to the extreme right or extreme left. And that is not a pathological nystagmus. Almost all of us can produce that if we force our eyes to go as far right or left as we can get them. Don't try this because it's quite uncomfortable. And it's so uncomfortable that you can't keep it up, and therefore your eyes start flicking backwards and forwards. In some children, endpoint nystagmus appears while their control of their eye movements is still developing, and they have endpoint nystagmus, and then it all disappears except in the extreme when the rest of us can get it. So endpoint nystagmus is not usually of concern. And then there's another type of nystagmus which is of no concern, and this is voluntary nystagmus when we see it in adults, excuse me, and known as ocular flutter in babies. And this is a lot more common than you would think. But let me show you what it looks like first of all, as opposed to the other sorts of nystagmus that we've seen, in which the movement is easy to follow. Voluntary nystagmus is a sudden, very, very tiny shudder that lasts for a few seconds and then stops. And about 5% of the population can actually do this as adults, and it's a sort of party trick. They can make their eyes wobble, and babies can sometimes do it. And what we don't know is whether the babies that do it grow up to be the sort of adults that can do it. Now, in adults, it's called voluntary nystagmus because they can make themselves do it. And different people have different ways of doing it, but all people who can do it will tell you that it involves constricting their muscles and making a huge effort. So some people can do it by gritting their teeth very hard. Some people do it by straining their neck muscles very hard. Some people do it by stressing the muscles of their face very hard, but it only lasts a few seconds because it's really, really hard work. Now, in children, it's not voluntary in the sense that they do it purposefully, but it always involves tensing muscles. So some babies do it when they're feeding. When the spoon goes towards their mouth, they get so excited that they tense their muscles and their eyes wobble as well. And other children will do it by tensing other of their muscles, but it always involves muscle effort. Okay? Children then grow out of it, but as I've said, we don't know if they then relearn to do it again as adults, but it's absolutely nothing to worry about at all if your child does it. Now, I have no reason to think that it is any more common in Down syndrome than it is in the general population, but it gets reported more in children with Down syndrome, because when you have a baby with Down syndrome, you are primed to worry because of all the negative information that you've been filled with after diagnosis, you are primed to look for all sorts of horrible things that are going to appear in your child. So when you see their eyes wobble with ocular flutter, most parents will worry and will then report it to their doctor or their optometrist or whoever. If you've got a typical baby, you're primed not to worry. And so if it happens, most parents will just dismiss it. Oh, look, did you see his eyes wobble then? Isn't that funny? What a clever little boy. And then they don't report it. But if you question parents when the children are a bit older, you'll find a lot of them used to do it as babies. So if that's the nystagmus that you see in your child, it doesn't matter. Okay, so what we'll do now is go back to the type of nystagmus that does matter, that pendular that turns into jerk nystagmus. Now, some children with Down syndrome grow out of nystagmus altogether in the first year. It doesn't go latent, it just completely disappears. And like a lot of aspects of nystagmus, it is a complete mystery. As far as I'm aware, typical children who have nystagmus, and typical children do get nystagmus, just not as commonly as children with Down syndrome, but typical children do not grow out of it. So it's even more mysterious when you realise that. But if you have a tiny baby who has nystagmus, there is a possibility that that nystagmus is going to disappear. Okay, but if they get to the age of 12 months, 15 months, and it's still there, it's very unlikely then to disappear completely, although it may go latent. The extent of eye movements, that's how much the eyes move, tends to get less as the child gets older. So you may worry when they're very tiny that you can't tell where they're looking and you can't tell whether they're making eye contact with you. It will be much easier as they get older because their eyes will move less and you will get used to judging where they're looking. And believe me, they are making eye contact with you. So let's look at the effects of nystagmus. The first one to be aware of is that if this is what we call infantile nystagmus, the sort that appears when a child is very young, the child does not see the world as moving. In spite of their eyes moving, the world looks completely static to them. Okay, now adults that have nystagmus will tell you that just occasionally they see the world as moving, but it's when they are extremely tired or ill. But when they're at their best, the world is as stable to them as it is to you and me. But their vision is poorer than anyone else at the same age. And I just want to show you a couple of graphs to illustrate that. So here's visual acuity, detail vision, the sort of thing we measure with a letter chart. Obviously, we do it differently for a young child, but you have all read a letter chart. So the numbers up the side of the graph roughly correspond to the size of the letters on a letters chart to give you an idea of context. And we've got age along the bottom in months. So when babies are very tiny, their vision is very poor. They may be able to see the top letter on the chart, although of course they won't be able to tell you what the letter is, and their vision improves really rapidly in the first 2 years of life. And it then starts to settle off, starts to plateau, but still carries on until the age of about 5 or 6, when it reaches adult values. And in fact, as you can see from the final dot on the graph, children do better than adults when they get to that age. Their vision is even better, because when you say typical adults, you've got a huge age range, and we all get a bit worse as we get older. So now we're going to superimpose on that children with Down syndrome. And this is children with Down syndrome who do not have nystagmus. And as the Down Syndrome Association and everyone else knows, children with Down syndrome don't see as well as typical children. So at every age, their vision is poorer. They don't ever get to the very bottom of the chart. They get about 2 or 3 lines of the chart poorer than a typical child. It starts off very bad, again, rapid improvement, but it never does reach what we think of as the normal level. Now I'm going to superimpose children with Down syndrome who have nystagmus, and their vision is poorer again. At all ages, nystagmus reduces detail vision. And that's very important for you to be aware of, that your child will not be seeing as clearly as you or as other children of the same age. And that means that every child who has nystagmus should be referred to the VI team. Every educational authority has a team of qualified teachers of the visually impaired whose job it is to support children who have vision problems. And they support from birth to 25 years. So you don't have to wait until your child is at school to have the support of a qualified teacher. Your child can be referred to them at any age. Excuse me. And referral is through the eye clinic, through the hospital eye clinic, through your paediatrician, or when the child does get to school, through the school. And you can ask the eye clinic, or you could ask your paediatrician to make that referral. Now, having said that, I just want to talk you through a survey that Down Syndrome UK and I did a couple of years ago, concerned about whether children with Down syndrome and nystagmus were getting the support they need. So what we did was carry out a survey of families who have children with Down syndrome and asked about whether they knew that their children had poorer eyesight than typical children or children with Down syndrome without nystagmus. And these are the results, and they are extremely worrying. So first one at the top left here, 37% of families were not told by the hospital how nystagmus affects their child's vision. That means those parents made the assumption that their child, in spite of their eyes wobbling, could see as well as everybody else. Now, of those, some were told by other people. They were told by a teacher, an optometrist, maybe their paediatrician, that the child's vision wasn't good. But 70% of those did not, the people who weren't told by the hospital, weren't told by anybody else either. And that means that a high proportion of parents who have a child with Down syndrome and nystagmus have no idea what that means as far as the child's vision is concerned. Now, I said that all children should be referred to the VI service. Down the bottom left here, 63% of children were not referred by the hospital, and 49%, that's almost half, were not referred by anybody else either, which means that half of children with Down syndrome and nystagmus are not being supported by the service that is intended to support them because they have not received the referral. And when I present this data to qualified teachers of the visually impaired, because I do a lot of training towards those teachers, and I've got another bout on Monday of teachers of the visually impaired, they are absolutely shocked because they don't go out looking for children to support. They make the assumption that all children that need their service are referred into them. And they're always dismayed when they learn that there's so many children out there that they are not supporting, because it means that those children are not getting any extra help in school. Teachers, ordinary teachers, and I'm not blaming them for not knowing anything about nystagmus, they don't realise that the children can't see their work as well as the other children. They don't know what impact nystagmus has, so they're not making modifications to the children's work. And if a child is struggling to do a piece of work, the teacher is going to assume it's because of the learning disability. They know the child has Down syndrome, they know that's associated with learning disability, and they think, oh, it's just cognitively too hard for him, when it's not. It is visually too hard, and if they make it easier by making it bigger, brighter, higher contrast, or whatever, the child may very well be able to do it. So it's really, really important that we make sure every single child is referred to the VI service. And that just at the bottom there reiterates what I've said. So the other effects of nystagmus, and there are other effects apart from detail vision, the child is slow to see. It takes much longer for a child to identify something that they're looking at than it does for us. Okay? And you can imagine that that's the case if your eyes are moving all the time, because you're looking at something now, as opposed to all the time when your eyes are still. Nystagmus also causes crowding, and that means a child finds it very difficult to find an object in an array. So the little picture at the top there, if I said to a child with nystagmus, go and find the Rubik's Cube, might not be able to find it because there's too much going on around it. If the Rubik's Cube is on a plain background with nothing else around it, of course they'll find it as fast as you or I would. But in a mixture, they simply can't do it. And that's something that teachers need to be aware of as well. The eye movements worsen, the eye moves more when a child is tired, ill, or stressed. And when their eyes move more, their vision gets poorer, their detail vision gets poorer, and more importantly, it gets slower. So the child really starts to struggle. So you find, again, this is something that teachers need to be aware of, because they might find that a child can do a task first thing in the morning, but when it comes to the afternoon and they're beginning to flag a bit, they can't do it. And we don't want teachers saying, come on, Billy, you could do it this morning. Don't pretend to me you can't see it this afternoon. Okay, and again, I wouldn't blame teachers because it's not their role to understand this. But it is the role of the QTVI, the qualified teacher of the visually impaired, to teach the teacher the impact of nystagmus. Oh, excuse me. Most children who have nystagmus have what we call a null position or a null zone or a null point, where the eye movement is least, and where the eyes move least, their vision is best. It's at its quickest and it's at its finest detail. And children don't like to move their eyes out of that position because their vision gets worse, because the movement gets greater. Now, for some children, they're very lucky and their null point is looking straight ahead. So their vision is best when they're looking straight ahead. For other children, and you can see the two illustrated at the bottom there, it can be when they're looking out of the side of their eyes. It can look when they're looking upwards. It can be when they're looking downwards. It can be when their head is tilted to one side. And we call that an abnormal head posture. And it's very important that children are allowed to use that head posture because that's how they see best. So, treating nystagmus. This is going to be very short because there isn't any treatment for nystagmus. There are some ongoing trials of medications, and there may ultimately be some medications that help nystagmus available. But for all of the trials, measuring visual acuity doesn't correlate with the patient's subjective experiences. So what these medications may be doing is speeding up vision, correcting that slow to see impact, rather than improving detail vision. But at the moment, we don't have a way of measuring the speed of vision. So at the moment, the only way these medications and trials can be researched is by measuring the effect on visual acuity. And it doesn't show much of an improvement. So we're a long way at the moment from treating nystagmus. If a null point is very exaggerated and is making life very difficult for a child, then surgery is an option. And what they do, a null point presumably works because the muscles are in a certain state of contraction, and that keeps the eyes moving least, wherever that might be, and it differs for different individuals. So what the surgeons try and do is tweak the muscles so that they are in that state of effort when the child is looking straight ahead. Now, if the null point's already straight ahead, that's fine. No one would suggest surgery. But if the child has a very exaggerated null position, then it might be beneficial to try and make the null point closer to straight ahead for the child. And you can imagine if the child has a null point which is like that, okay, the child walks around with their head back all the time, putting strain on the neck, not able to see their feet, not able to actually see whether there's anything they're going to trip over, makes a huge difference to the child's life, makes it very, very difficult. And that might be a case in which the parents would want to discuss surgery for the null point. Okay, we've said that acuity, visual acuity, detail vision is poor. So the way that's managed is the same as it is for any child with poor vision. Text enlarged, text made bold. The child should write not in pencil, which is very difficult to see, but in black pen or soft artist pencil, which is very, very soft lead and makes a very black, very dark line. And when the child is learning to write, making sure the lines they write on are black, not that faint blue that we're all used to, which is probably invisible to a child with nystagmus. So there's very simple things that can help make things more visible to a child who has nystagmus or any other form of visual problem. The child is slow to see, so teachers need to allow extra time for tasks and to shorten tasks because nystagmus makes it hard work for a child to use their eyes and they tire very quickly. So short tasks but give them longer to perform it is really important. Nystagmus causes crowding, so the children need a clear workspace. And at home, think about if you're putting the child's clothes out for them in the morning, don't put them on the bed on a patterned duvet because the child won't be able to find them. If they've got a patterned duvet, then pull the duvet back and put the clothes on the plain sheets so they can actually find what they're looking for. And if they're looking for toys, spread the toys out so that they can find what they're looking for. Try not to have patterned tablecloths. Try again to make everything widely spaced and against a contrasting background. Nystagmus is going to get worse when a child is tired, ill, or stressed. For some children, this is really unfortunate. It gets worse when they're excited as well. Okay, so just before Christmas, the children's eyes just go haywire, and they really do struggle in school. And we need to be aware of when and what affects your child. So avoid stress. The teacher needs to recognize if the eye movement becomes more visible. That's a very reliable sign that the child needs a break, and so on. And then there's this null point. Okay, now I have said the child needs to be allowed to make use of their null point. Now, if their null point is straight ahead, that's fine. They're sitting comfortably and their eyes are naturally in the best position for them. But if the null point is anywhere else, the child is going to have to move their head to look straight ahead using their null point. So you and the teacher need to think about rearranging the seating at home and in the classroom so that the child doesn't get a crick in their neck from using that head posture all the time. So if a child needs to look straight ahead by moving their eyes to this side, you need to sit them over here so that what they're looking at is over there and their eyes are in their null point. So try to arrange things so that the child can keep their head straight and comfortable, but what they're looking at is in the direction of their null point. Now, if a child is using an abnormal head posture all the time, I've said they may get a crick in their neck and they can get pain and muscle changes in their neck from adopting an unusual posture all the time. So if that's the case, that child will benefit from physiotherapy. And the physiotherapy is not designed to straighten their head because we want them to use their null position, and it's important that the physiotherapist knows why the child has an abnormal head posture, but they need physiotherapy to stop them getting consequences of that muscle strain. To stop it becoming a permanent fixture, they need some exercises to make sure they keep good movement in all directions and their muscles don't get stuck in that one position. And I found this photo. This is a team in a clinic in America that works specifically with abnormal head postures. And I don't know who these people are, but it really made me laugh because all three members of staff have got an abnormal head posture, and the only one who hasn't is the child that presumably they're trying to treat. So I just thought that was a really funny photo to advertise a clinic that is supposed to treat abnormal head postures. And that's all I've got to say about nystagmus, but I've got lots of time for questions. My email is there, so jot it down if you need to. If you think of a question later, tomorrow, next week, next month, okay, you can email me at any time. Now, Lucienne, I'm sorry, I forgot to say, I'm very hard of hearing. So I want questions in the chat box or the Q&A, please, not
okay,
over
that's
the
great.
microphone, because I'm just going
to stop recording so that the questions don't go